Expression of CK19 as a biomarker in early detection of oral squamous cell carcinoma. Department of Oral Pathology and Microbiology. What is OSCC? A malignant epithelial neoplasm exhibiting squamous differentiation is characterized by the formation of keratin and/or the presence of intercellular bridges. Pindborg J.J. et al., 1997. Most common malignant neoplasm of the oral cavity, more than 90%. Squamous cell carcinoma, keratoacanthoma, self-healing, carcinoma, pseudocarcinoma, keratocarcinoma, keratoacanthoma type. Keratoacanthoma is a self-limiting, epithelial proliferation with a strong clinical and histopathologic similarity to well-differentiated squamous cell carcinoma. Cutaneous lesions presumably arise from the epithelium of hair follicles. Ultraviolet light exposure appears to be a major risk factor, with most solitary lesions arising on sun-exposed skin in older adults. Additional potential contributing factors include X-ray radiation, tar exposure, immunosuppression, certain drugs, such as RAF inhibitors, hedgehog pathway inhibitors, and PD-1 inhibitors, foreign materials, such as tattoos and cosmetic fillers, trauma, such as burns and surgical procedures, other skin conditions, such as lichen planus and psoriasis, and HPV or human polyomavirus 6 infection. Clinical features. Mostly affects older men. Minimal pain during the early growth phase. OSCC has varied clinical presentation, including the following: exophytic, mass-forming, fungating, papillary and verruciform. Endophytic, invasive, burrowing and ulcerated. Leukoplakic, white patch. Erythroplakic, red patch. Erythroplakic, combined red and white patch. The leukoplakic and erythroplakic examples are probably early cases that have not yet produced a mass or ulceration. An exophytic lesion, surface that are irregular, fungating, papillary or verruciform. Color, normal to white or red, depending on the amount of keratin and vascularity. Surface is often ulcerated, feels hard on palpation. Endophytic growth pattern, central, depressed, irregularly shaped ulcer with a surrounding, rolled, border of pink, red, or white mucosa. The rolled border results from invasion of the tumor downward and laterally under adjacent epithelium. Perineural invasion may cause paresthesia. Destruction of underlying bone, when present, may be painful or completely painless. Epidemiology. The incidence ranges from approximately 2 to 10 per 100,000 population per year. Differs widely in various parts of the world. Basis of environmental differences or lifestyle and habits among certain populations, such as betel quid chewing, snuff dipping, or the habit of reverse smoking. The incidence of oral carcinoma in blacks is somewhat lower than in whites. Male-female ratio is approximately 2 to 1 after the 4th decade. Carcinoma of the vermilion border of the lower lip, strong male predominance. Southeast Asian scenario. In India, oral cancer, constituting 9.8% of an estimated 644,000 incident cancer cases in 1992, ranks first among all cancer cases in males. Third most common among females in many regions, with age-standardized incidence rates 7-17 100,000 persons per year, the incidence rate being higher than the Western rate of 3 to 4 100,000 per year. The mortality rate is lowest for lip cancer, 0.04 per 100,000. The mortality rate is highest for the tongue, 0.7 per 100,000. Possible etiological factors: tobacco smoking in the form of pipes, cigars, cigarettes, bidis, reverse smoking. 40 cigarettes per day, R increases up to 10 to 20 times. Smokeless tobacco in the form of snuff dipping, tobacco sachets, and tobacco chewing like betel chewing and betel quid. Smoking is considered to be a major etiological factor, particularly in association with alcohol. Main carcinogens in tobacco are N-nitrosamines derived from nicotine. Alcohol may enhance transport of carcinogens across mucosal barrier. Etiological variables. Nutritional deficiencies in alcoholics may impair mucosal barrier. Deficiencies of vitamin A, C, E and iron are contributory factors. High fruit consumption decreases the risk of oral cancer. Poor oral hygiene, faulty restorations, sharp edges of teeth and ill-fitting dentures. Sun, ultraviolet light is thought to be an important factor. Human papillomaviruses, HPV types 16 and 18, Epstein-Barr virus, EBV, and human immunodeficiency virus, HIV, are an important factor. Immunosuppression. Molecular abnormalities. Genetic mutations are responsible for generation of malignant cells. Mutations may result in abnormal quantity and/or function of protein products that regulate cell growth, division and repair. What is cytokeratin 19? It is an intermediate filament protein that serves as a valuable marker for the identification, monitoring, and staging of intrahepatic cholangiocarcinoma, ICC, with increased levels associated with tumor development and postoperative outcomes. Basic information. Smallest cytokeratin, 40 kDa, found in simple epithelia and basal, parabasal layers of stratified squamous epithelium. Functions as part of the intermediate filament network, structural support for epithelial cells. Role in oral pathology. Premalignant lesions. CK19 expression increases, e.g., leukoplakia, erythroplakia, OSCC, overexpressed, especially at invasive fronts. Downregulation right-pointing arrow terminal differentiation. Upregulation right-pointing arrow indicator of malignant transformation. General features. Cytokeratins equals intermediate filament proteins, specific to epithelial cells. CK19. Smallest keratin, 40 kDa, non-keratinizing type. Expressed in simple epithelia and in basal, parabasal layers of stratified squamous epithelium. Provides structural integrity and is a marker for epithelial origin. Normal expression pattern. Normal oral mucosa. CK19 expression is weak or absent in suprabasal layers. Present only in basal, parabasal cells. Plays a role in epithelial differentiation. Downregulation of CK19 is linked with terminal differentiation of squamous cells. Altered expression in oral pathology. Oral premalignant lesions, leukoplakia, erythroplakia, lichen planus with dysplasia, CK19 expression is upregulated. Seen in suprabasal layers, abnormal finding, oral squamous cell carcinoma, OSCC, CK19 shows strong overexpression. Especially at invasive tumor fronts. Suggests role in tumor invasion, dedifferentiation, and malignant transformation. Diagnostic role. Tissue-based detection. Immunohistochemistry, IHC, used to demonstrate CK19 expression in biopsy specimens. Saliva, serum biomarker, Cypher 21:1, non-invasive detection method. Helps distinguish normal, premalignant, and malignant lesions. Body fluid detection. Soluble CK19 fragments, Cypher 21:1, detectable in saliva and serum. Offers a non-invasive biomarker option. Can help differentiate between normal epithelium, premalignant lesions, malignant lesions, OSCC. Clinical significance. Early detection of malignant transformation in oral lesion. Prognostic marker. High CK19 linked with aggressive tumor behavior and poor outcome. Non-invasive screening tool, saliva, serum assays, Cypher 21:1, may allow easier patient monitoring. Adjunct tool, when combined with other markers, improves diagnostic accuracy. Limitations. Not fully specific right-pointing arrow also expressed in some benign epithelial conditions. Cannot be used as a standalone marker. Needs to be combined with other biomarkers, P53, Ki67, P16, etc., for reliable results. Further research required for routine clinical application. Summary statement. CK19 is a reliable biomarker to indicate early malignant transformation in oral mucosa. Its overexpression in premalignant and OSCC tissues, along with its detectability in saliva and serum, makes it promising for both diagnosis and prognosis. However, due to its lack of absolute specificity, it is best used in combination with other markers. Expression of CK19 as a biomarker in early detection of oral squamous cell carcinoma. ABSRACT. Background. Increased mortality in oral squamous cell carcinoma, OSCC, had been attributed to delay in diagnosis. Lack of a specific marker to assess the malignant potential of premalignant lesions is thought to be one of the reasons for late detection. Expression of cytokeratin 19, which is widely used as an odontogenic epithelial marker, had been reported in OSCC. Downregulation of CK19 expression plays an important role in terminal differentiation of superficial squamous cell, and increased expression in various epithelial malignancies has been suggested to be an indicator of malignant change. Aims and objectives. To assess the role of CK19 as a potential marker in predicting malignant transformation in oral precancerous lesions and as a prognostic marker in OSCC. Introduction. Oral squamous cell carcinoma is the most common malignancy of the oral cavity. This can either develop as de novo or can be preceded by a state of premalignancy known as epithelial dysplasia, which is characterized by changes in architectural and cellular levels. The role of biomarkers in detecting epithelial dysplasias has been studied by various authors, including the expression of cytokeratins. CK19, an odontogenic epithelial marker, has also been reported to exhibit increased expression in various cancers, including OSCC and also in oral epithelial dysplasias. The studies carried out to assess the expression of CK19 in oral epithelial dysplasias and OSCC are limited in number, and solid evidence regarding the authenticity and reliability of this marker is insufficient. Hence, it was planned to carry out a study to assess the expression of CK19 in various grades of oral epithelial dysplasias and OSCC and to evaluate their role as a potential marker in predicting malignant transformation in precancerous lesions. Materials and methods. Study was conducted with approval from the Ethical Committee, Amrita Institute of Medical Sciences and Research Center. The study population consisted of patients diagnosed with hyperplastic epithelium, epithelial dysplasias, and squamous cell carcinomas. The paraffin-embedded blocks of hyperplastic tissue, N equals 10 cases of all three grades of oral epithelial dysplasia, OSCC, and tissues obtained from normal oral mucosa were retrieved from the archives of Department of Oral Pathology and Microbiology. The samples were categorized as Group 1 IV. Group 4 comprising of OSCC were graded as well-differentiated, moderately differentiated and poorly differentiated OSCC based on Broder's criteria. Immunohistochemical staining using cytoskeletal marker CK19 was performed as per the standard protocol for indirect technique. Following clearing and dehydration, the tissue sections of 5 thickness were transferred to citrate buffer and autoclaved for antigen retrieval at 15 pounds pressure for 15 minutes. After washing in PBS, endogenous peroxidase blocking was done by dipping sections in freshly prepared 3% H2O2 for 10 minutes. After blotting the excess peroxide, the slides were treated with a protein block reagent. Sections were then incubated with primary antibody CK19 at room temperature for 1H. The sections were taken out were washed in PBS, 3 changes, for 5 minutes each to remove the excess antibody. A drop of enhancer from the secondary antibody kit, Pathin Z2 Private Limited, was added, and the slides were incubated for 30 minutes followed by the addition of a drop of streptavidin from the secondary antibody kit on the sections and incubated for 30 minutes. The sections were washed in 3 changes of PBS for 5 minutes each, and a drop of freshly prepared DAB. 3. Diaminobenzidine tetrahydrochloride, a substrate chromogen, was added on both sections. Slides were washed in PBS to remove excess DAB and then counterstained with hematoxylin. The tissue sections were mounted with DPX. The sections were initially scanned at low power. A prominent brown cytoplasmic staining was considered positive for samples selected. The positively stained cells were scored using the all-red score, 4, in 3 microscopic fields at times 40, that comprises proportion score and intensity scores as given in Tables 1 and 2. Table 1. Scoring criteria, proportion score. Proportion score scoring criteria, 0 no cells are plus. 1 is less than or equal to 1% cells are plus. 2 1% to 10% of cells plus 3 11% to 33% of cells plus 4 34% to 66%. 5 67% to 100%. Table 2. Scoring criteria, intensity score. Intensity score scoring criteria, 0 none 1 weak, 2 intermediate 3 strong. CK19 positive cells showing different hues of brown color in cytoplasm, IHC, times 10. Normal keratinized oral mucosa, H&E, times 4. B. CK19 expression restricted to the basal layer. IHC, times 4. Normal non-keratinized oral mucosa, H&E, times 4. B. CK19 expression restricted to the basal layer, IHC, times 4. Comparison of CK19 expression in oral epithelial hyperplasia with varying degrees of inflammation, AC. Mild inflammation, B. Moderate, C. Dense inflammation. H&E, times 10, DF. Progressive increase in expression of CK19 with increase in grades of inflammation, IHC, times 10. Mild epithelial dysplasia, H&E, times 10, B. CK19 expression restricted to basal and some cells in parabasal layers of epithelium, IHC, times 10. Moderate epithelial dysplasia, A. H&E, times 10, B. CK19 expression restricted to basal and some cells in parabasal layers of epithelium, IHC, times 10. Severe epithelial dysplasia. A. H&E, times 20. B. CK19 expression involving cells of basal, parabasal, some spinous and superficial cells, IHC, times 20. Table 3. Comparison of mean all-red scoring index in various grades of oral epithelial dysplasia using Kruskal-Wallis analysis. 3 subgroups N mean SDP. Mild dysplasia 10.4.803.4900.007. Moderate dysplasia 10.2.902.846. Severe dysplasia 10.12.507.692. Comparison among grades of oral epithelial dysplasia. In OSCC, out of 10 samples of well-differentiated OSCC, 8 samples showed positive expression of CK19 in the superficial epithelium. An obvious difference in expression was noticed in the expression of CK19 in the areas of invasion and the rest of the areas. In areas, other than the invasive front, the expression of CK19 was seen to be cytoplasmic and was distributed as focal interspersed positivity involving the cells of basal and occasionally parabasal layers. The superficial epithelium at the areas of invasion showed a stronger cytoplasmic positivity involving the basal, parabasal and superficial layers. Superficial epithelium at the invasive front in well-differentiated oral squamous cell carcinoma. H&E, times 20. CK19 expressions in the same area, B, IHC, times 20. In well-differentiated OSCC, most of the islands showed negative expression of CK19. A few islands in superficial connective tissue stroma showed positive CK19 expression. Since a difference was noticed in CK19 expression between the well-differentiated islands showing keratin pearls and the less differentiated islands without keratin pearls, these two were evaluated separately, keeping 30% as the cutoff value of keratin pearls. An increased expression of CK19 was noticed in islands greater than 30% keratin pearls, suggesting an increased expression of CK19 with differentiation. In the case of invading islands of moderately differentiated OSCC, a diffuse scattered expression was noticed with a strong positive expression in some malignant epithelial islands situated superficial in the connective tissue stroma. CK19 expression in oral squamous cell carcinoma, AC, A. Well-differentiated oral squamous cell carcinoma, B. Moderately differentiated oral squamous cell carcinoma, C. Poorly differentiated oral squamous cell carcinoma, H&E, times 10, DF. CK19 expression in increasing grades of oral squamous cell carcinoma, IHC, times 10. In poorly differentiated OSCC, invaded epithelial cells distributed in the form of nests, islands and sheets showed a uniform strong cytoplasmic positivity in 8 samples of this group. Strong cytoplasmic positivity CK19 noticed in malignant epithelial cells distributed as nests and islands in poorly differentiated oral squamous cell carcinoma, IHC, times 20. Comparison of mean all-red scoring index in various grades of oral squamous cell carcinoma using Kruskal-Wallis analysis. IV subgroups N mean SDP. Well OSCC 10.1.801.9890.244. Moderate OSCC 10.2.202.251. Poor OSCC 10.3.502.877. Comparison among grades of oral squamous cell carcinoma. OSCC still remains a major global health problem, with an overall 5-year survival that has remained at 50%. Hence, a reliable tumor marker can be useful in the early detection of OSCC and monitoring the response to therapy. CK19 is an exceptionally unique type 1 cytokeratin that is being studied extensively as a differentiation marker, stem cell marker, premalignant, malignant and metastatic marker, as well as diagnostic and prognostic marker too. Summary and conclusion. In normal oral epithelium, basal expression of CK19 was noticed in tissues from keratinized as well as non-keratinized mucosa which usually do not express CK19. An increased expression of CK19 was noticed in areas of inflammation, suggesting the role of inflammatory cytokines produced by the chronic inflammatory cells in the subepithelial connective tissue in inducing the expression of CK19 in the overlying epithelium. Our findings showed that increased expression of CK19 occurs with hyperplasia and severe dysplasia. In case of mild and moderate dysplasias, CK19 expression was found to be lower than that of normal mucosa. However, an abrupt increase is noticed in severe dysplasia, suggesting that during the initial phase of dysplasia due to some reason, the expression decreases and as the lesion progresses to the advanced stages of dysplasia, the expression increases. A similar increased expression was also noticed in the superficial epithelium at the invading front in OSCC. A progressive increase in expression with progression of dysplasia was not noticed in the present study. From these findings, we may conclude that CK19 expression is induced in later stages of progression in epithelial dysplasias. 4. In OSCC, the expression of CK19 was restricted to either a few islands or a few cells within the islands, thereby bringing CK19 expression to a value less than what is noticed in normal epithelium. The malignant epithelial islands in the superficial connective tissue stroma were showing greater expression than the deeper islands, and those epithelial cells associated with the formation of keratin pearls were found to be showing more expression than those with infrequent keratin pearls. 5. Our study questions the use of CK19 as a single stem cell marker in the diagnosis and prognosis of oral cancer, as it is found to be expressed only in certain phases of progression. 6. Although it cannot be used as a progression marker, as a significant increase in expression is noticed in severe dysplasias and invading the front of the superficial epithelium in OSCCs, it appears that malignant transformation of epithelium can be predicted based on the increased expression of CK19. However, it should be done with caution, as a similar increased expression can be noticed in the presence of inflammation too.